It's on the heart, and we're going to start looking through some of these slides, mainly the pictures. You can always read the book because the book has great things to talk about, but I always like to look at the pictures first. Many people have seen something similar to this. Guys, this is always like if you look at an anatomy coloring book about the heart, they'll throw this picture in there. And some folks do seem to be kind of like, wait a second, what is all this? All they did was put the heart in the center, and they're showing that there's two sides to the heart. You can see the blue, the right side, and the red is the left side. So one of the things about the heart that is just one of the basics is that it's a double pump. It's two pumps in one place. The right side is going to be the pulmonary circuit. When they talk about, the right side, they're going to say the right side of the heart pumps to the lungs. And so the pulmonary means lung. You can see that this, basically the blood's coming in from the head area, let's say. The systemic is the body, so up in the body, up in the head. This would be representing the superior vena cava, which is not labeled. We'll see these pictures later, right? But that's superior vena cava going into the right atrium, and then the inferior vena cava going into the right atrium from the system. So what happens? It's going to be pumped to the lungs. It has to go into the right ventricle, and the ventricles are always stronger. We should always remember the atria are weaker. Think of an atrium to a house like the foyer. It's where the people walk into the house if you have a nice big house, right? And then the ventricle would be the pressurized chamber. So guys, we're not going to label, this whole thing. Let's keep it kind of general. We see the right ventricle basically going to the lungs, and we're going to look at better pictures and talk about all these different pipes. But whenever you go to the lungs, that's where you're going to pick up the oxygen, and then you're going to have blood go back to the left atrium, right? That's the left atrium there. Then it goes through a valve into the left ventricle, and then out the aortic valve and the aorta to the body. Okay, so this is just the simple schematic of the blood flow. So when we get into the heart anatomy, this is a great slide. Like, this textbook gives some really good pictures of things that are kind of a extra detail than what you've seen before, probably. I kept this one in here mainly because it shows you a few terms. Like we see endocardium, guys, so we're going to see another picture later. The endocardium is what touches the blood. You can think that the blood's in there. And it's very, very thin. It's like paper thin. The myocardium is the muscle. Myo means muscle. So we see that, the ventricle is the best place to look at a thick muscle. Myocardium is the thick cardiac muscle. And then we see, it gets pretty detailed here. Visceral layer of the serous pericardium. How do you like that? Guys, remember, visceral just is the covering of any organ, and this would be basically the outer boundary of the heart muscle itself. And there's a space, right? You guys have heard of the pericardium in general, and actually, if we look up at this top picture, it does show you where the space is. Like this dark area is labeled pericardial cavity. And honestly, they're exaggerating the depth there, the distance, and that's just to show us that. In real life, it has not got a space like a distance. They're touching each other. And when the heart beats, it doesn't grind on the tougher part. Like if you think about this white area, and it's labeled parietal layer of the serous pericardium, this area is the tough part of the pericardium, which covers the whole heart. And so this allows for slippery, no friction. Heart beats, we don't feel it rubbing on the inside of the pericardium. So there are conditions when you do cut through and do like a heart surgery and you actually cut through to get into the heart, where this pericardium, they call it pericarditis, and it becomes inflamed and irritated for some people. If you had an infection, it could fill up with blood, pus, or some sort of liquid or air sometimes. Anyway, so that's all we need to look at that. here's a nice zoomed in picture of what we just looked at, really. Um, it's kind of neat because it shows us the small blood vessels actually in the heart muscle, those little arteries and veins. And here's the endothelium, so that's where the inside of the heart would be. You can see a little fatty layer. Guys, I'm not going to have you label all this. The most important thing to know is that we do have, this is technically epithelium. When you think about the cover, look at this, simple squamous epithelium. So epithelial tissue, we've mentioned, is the covering of the body, and we see that on even the endothelium and the outer area here. And that's cardiac muscle. Okay, so here's the most important, here's the big picture of the heart, right? And most of us have seen this before. A lot of times I'll have people draw out a simple sketch, and in lab we can do a little, worksheet, and I think many of you have done it since we've taken the biology class to get here. When you look at a model of the heart, I don't know, if you go to the superior portion, there's 3 large pipes. That's where I start oftentimes if I look at a model. And the aorta is in the middle. When we dissect our cats, it isn't exactly the shape because cats are a little different, but you basically look for 3 pipes. The superior vena cava, which would be on the cat's right, and then the aorta, and then the pulmonary trunk. We'll see a view that slices off, it does a coronal section. The next slide will have a slice off the front of the heart, and we can see where blood goes in here. But if we think about it in this viewpoint, the right atrium is here. Guys, always the atria are on top. Okay, so here's a right atrium and a left atrium. A lot of times I'll draw a little smiley face on this above, and that way you don't mess up which side's which, right? This is a patient looking straight at you without a body. This is Tim. That's Tim's heart. So it is true that the atria do have a different color, and they kind of look like leaves sometimes, and there is a little groove in between. If you look at a big heart, if you've done a frog heart dissection, you can't really see it, or fetal pig, you can't really see it in detail. But the bigger the hearts, you do see the differences. The right atrium here would be where blood would enter through the superior vena cava, and the inferior vena cava goes behind. You can't see where it goes in, but it's going in the right atrium. And that's just big cave. Think about it. Superior is above, vein, cave. This is the big vein cave. So we see this little bitty, they're calling it the right coronary artery. So we're going to see later on that there's a picture of the coronary arteries coming off the aorta. They actually come off the back of the aorta, and we can see it coming out through this little crack. And that's the right side. The left side also comes off up here, but we can see it's over on the left. And there really are 2 coronary arteries. We need to know the arteries to the heart itself are coronary arteries. And I will say, guys, it's just interesting, when you think about blood flow, we've all heard of heart attacks, myocardial infarctions, they call them MIs. This one over here, I'm just highlighting a couple little details here. We see the left ventricle on the left inferior of the heart, and there's another name of this one that I like better than what our book's giving us. This is what you call the LAD. And it means left anterior descending. And think about it. It's on the left side, it's on the front of the heart, anterior, and it's going down. And that is the one that is also called the widowmaker. Because if you shut this down, if you were to have a clot right where that dot is, the left ventricle would suffer, and that is a bad thing. If you have a small myocardial infarction over here on something like where this dot is right now, it's not a very big artery. It would shut down circulation to just a smaller portion of the heart, and also, not the left ventricle. It still would be bad. But I just, when I was a student, and you hear about people surviving heart attacks, they say mild heart attack. Well, that would be a smaller blood vessel here. If you have a massive heart attack that are typically fatal, it's a larger blood vessel, and definitely if the left side is impacted, or if the left side is what's going on, it's worse. So LAD is the widowmaker. Other things in this picture, a lot of people will ask about this little bitty piece right here. This is not a pipe, it's just a ligament. And so they called it the ligamentum arteriosum because it kind of looks like it might be an artery. But blood does not go in between those two things. This is just to help hold it together. Also with this picture, we need to look, if we follow the pulmonary trunk up and we go out to the right or left, we don't see a lung over here. But technically, if you look at this, it says left pulmonary artery. It's blue, okay? So think about that. Blood in this artery is not oxygenated because it hasn't gone to the lung yet. So there's always a test question. What is the only artery of the adult human that doesn't have oxygenated blood? And it's the pulmonary artery. And then if you think about a lung being out here to the side, we're going to gather our oxygen, we're going to have that occur, and the blood will turn red, and look where it goes in. There's actually a superior and an inferior portion at first, so that's why you see two of them on both sides. You see two here. There's a superior and an inferior. These are the pulmonary veins, and they're the only red veins in the body. Okay? So remember, arteries go away from the heart, veins go towards the heart. So here we have veins going towards the heart that are red. So it's one of those details they always ask about somewhere. And you can't really see where it goes in. It's going into the left atria. Okay? This one's going way back behind into the left atria. And then blood's going to go into the left ventricle and then out the aortic arch. This is actually the aortic arch right here. You could call this the ascending aorta, the aortic arch, and then behind the heart would be the descending aorta. A lot of people will call it the thoracic aorta behind the heart, and that's fine. Either way is fine. I prefer thoracic aorta because when you go into the abdominal region, they call it the abdominal aorta. They don't call it the lumbar aorta. That'd be kind of weird. I've never heard that. So let's look at our next picture. Oh, okay, so this one actually is the back of the heart, and this is a good one to just kind of look at quickly, guys. It gets a little confusing. We're not going to have to label anything on the back of the heart, but I do think it's kind of useful to see some different pictures. Look at our pulmonary veins, look at the pulmonary arteries. And like, think about what a sinus is. It's a cavity. You can see how as the coronary arteries bring blood into the heart uses those nutrients and deoxygenates the blood, so we have cardiac, veins that go back into a cardiac sinus. But really, this is just another view we don't need to label this and get real technical on this slide. This is the one that I wanted to show you because this is another frontal view, right? This is the, one of those, this is probably the most important picture of this whole chapter. They have sliced off the front of the heart, and you can follow the blood flow a little bit easier. Here's our right atrium. We see a valve right here. So let's talk about these valves. And the book has actually, let's do them in order, okay? Like this would be the first valve that we run into, and they call it the right atrioventricular valve. Guys, the word atrio comes from atrium, and ventricle, right? Ventricular. So this valve is in between the A and the V on the right. That is the anatomical name. And on a test or real life, they typically don't use that. They call it the street name. And there's basically, if you look at the AV on this side and this side, we have two of them. I personally like to label this one first because this is the one that has three names. Okay? So let's name this one first. It's not, these two are identical. If you think about them, they're both AV. Here's the right AV. Here's the left AV valve. This one is what I call the Be My Lover valve. Okay? The book doesn't tell you this. I call it the Be My Lover valve because the B, it means bicuspid. You're going to hear people call it the bicuspid. It's BICUPID. And the my for Be My is mitral. Mitral is the other name that is commonly used for this valve right here. And I know the book didn't use those names here. They do later on. We want to make sure we know that this left AV valve is the bicuspid or the mitral valve. It's spelled MITRAL. And once you do that one, and you know that there's another AV valve, it makes it real easy to know that this one here is called the tricuspid. Okay? And honestly, the reason why these do have these names, tricuspid and bicuspid, this one here is the tricuspid, is it looks like it has three cups. Cuspid means cup, and whenever doctors look at it, they think it looks like it has three cups. I don't see it. I don't do heart surgery. But that's how they got these names. The one over here, the bicuspid, looks like it has two cups for bi. And it also looks like it's mitered, like a miter joint in woodworking, so they call it the mitral valve. We cannot see the aortic valve in this picture. It would be up in here. And that one's easy, guys. Aortic valve is just like the valve right before the aorta. And then here we have the pulmonary valve. They did label that. Pulmonary valve is right at the exit of the heart before going to the pulmonary circuit, right? Because here's the pulmonary trunk, pulmonary arteries going to the lungs. That's the beginning of the pulmonary circuit. The aortic valve is at the exit of the heart right before the systemic circuit, because it's going to, right before it goes to the whole body. So basically, to kind of repeat this, we've got four valves, but some of them have multiple names. The first one is here, right? That's the right AV valve. That's what I'm going to call it right now. Blood is going to go from the right atrium through the right AV valve into the right ventricle, be shoved up through the pulmonary valve, through the pulmonary circuit, to the lungs, back into the pulmonary veins, into the left atria, through the mitral valve. Notice I changed, that's one of the correct names. I could have said bicuspid. And then this is the left ventricle, and it's kind of hard to see. Basically, this left ventricle is bigger, more posteriorly, and our aortic valve is more posteriorly behind all of this stuff. So, this left ventricle looks like it's kind of small in volume, but it's bigger than this. If you compare this viewpoint, this right ventricle looks like it has more volume, and it's just because of where they sliced the heart. This slice was done here to show the chordae tendineae. Okay, so look at those little cords. These are called chordae tendineae that you only see on the cuspid valves, which are the right and left AV valves. If someone said, my semilunar valve is messed up. Now, I haven't mentioned that, and it's kind of getting annoying, isn't it? How many names of valves do we have? Well, we should just remember there are two cuspid valves. Those are the bicuspid and tricuspids. And then the aortic and the pulmonary actually look like moons. So when you read the book and you look at different pictures, they are going to describe, and they actually did right here, aortic semilunar valve. They included it in the name, which was nice. And actually, I will say they did label it right here, so I didn't quite see that. But basically it's hidden. I think they honestly stretched that a little bit to make it show up in the picture. It's not really that low. It's a little higher up, but anyway. So just remember that the semilunar valves could either be the aortic or the pulmonary. So I don't like it if I'm reading a report and somebody says semilunar valve problem, because I ask myself, well, which one? Now, I will tell you that they do research on people who have valve problems. And the people, guys, there are people that have what you call bacterial vegetation on these valves, especially these. It's kind of scary. The dentists say brush your teeth because if you have bad teeth, the bacteria can mess up your heart. And it's true. When you take microbiology, it's talked about in the first chapter of the book, and it's really spooky. It's called bacterial vegetation. There are people all the time that are in their 40s going and having open heart surgery to change the valves because they've been basically taken over by or like if you think about algae on rocks, that's kind of how the bacteria hooks up to these and it doesn't leave. And you can't scrape it off and drugs can't get them off. So you have to have valve replacement surgery. Talking to some people that do heart valve jobs, and I don't remember the detail, but I can tell you, if you're an IV drug user, the bacteria off the needles that people get in their bloodstream like certain valves, versus if you just have bad teeth. So a lot of people go into the hospital, and if they're like my age, about 40 something, and the doctor says, well, you need a valve job, they can kind of tell if you're an IV drug user or not. Anyway, and I will say it's easier, believe it or not, the aortic valve, if you think about it, I'm circling it here, right before the aorta, because it's the easiest place to think about it. That is at the most pressure, right? The most pressure coming off the heart is right there. But surprisingly, changing the aortic valve is easier than one of the AV valves. And that's because these are inside the heart. It's easier to do surgery on outside of the heart than inside the heart. It kind of makes sense. Anyway, so make sure you know the chordae tendineae are going to the AV valves. And there's a little bitty nipple-looking muscle. Like, guys, the papilla. The word papilla means nipple. And so this looks like a nipple. And so what is the name of those little muscles? Papillary muscles. Remember the papillary layer of the dermis? It's based on the nipples. And the reason why I wanted to show you these, probably, I don't know, did you guys remember that stuff from Bio 115, maybe? It's hard to remember all this, right? It's really a clinical, it's really significant to kind of know about these if you're dealing with heart people. What happens after the heart attacks I was describing, I didn't describe a lot of things, but basically if you had a heart attack that affected a papillary muscle, they're going to die about 2 days later after the heart attack. So let's say somebody survives their heart attack and they're in the hospital and it's day 2 at the ICU. That is whenever the nurses really watch them closely for valve flutter and all of a sudden the valves stop working if they've been affected. And that means more trouble. So a lot of, really after a heart attack, about 3 days afterwards is a good point. You kind of know what's going on, because people can survive and then have a major problem with these. Because if you think about it, if these muscles don't pull on the valves and do what they're supposed to do, well, how does blood work, in there very good? So there's no chordae tendineae and no papillary muscles hooked up to the pulmonary or the aortic valves, only the AVs. Look how thick the ventricle is. On the left, especially, right? Over here on the right side, it's fairly thick. Look how thin the atria are. Very thin. This thing called the fossa ovalis, basically, if you think about anybody who you've heard have heart murmurs, they worry about heart murmurs with young kids. It is very possible for us to develop and not have a closure of the atrial septum. They call it atrial septal defect. They talk about it in your textbook. The hole in the heart. The most common place for that is in between the right and left atria, and it might be a little hole like even smaller than this laser pointer, or it might be as big as the laser pointer, or a little bigger. That's where you can get a murmur, in which that means a strange noise of blood. They can easily repair those by putting probes up the femoral veins and going up the inferior vena cava into the right atrium, and they basically can put a little piece of, material there and fill the hole. It's a very easy surgery. If someone lived for 40 years with a large hole, their heart works harder, and as a result, they can get what you call cardiomegaly. So cardiomegaly is just big heart. But I want you to think about this structure here. We have, a pretty thick wall. What happens when you get cardiomegaly? The muscle gets bigger outwardly, so it grows bigger. Like, they say that the heart is about as big as your fist. So if you were to open your fist up, and put a racquetball in there, that would be about how big cardiomegaly could get. But the problem is it also grows inward. The heart muscle grows inward. So what happens is you have less room for blood to actually get through the pumps, and it's like a downward spiral. And that's where you can get congestive heart failure, and the only way you can fix it is a heart transplant. John Q. Anybody seen John Q? Denzel Washington. It's a good movie. Denzel, and he's a stud. He goes and he takes over this whole hospital because his little boy needs a heart and insurance wouldn't pay for it. And he holds this doctor hostage. Seriously, it gets good. They couldn't find a donor, and Denzel told the doctor, he holds a gun to his head and says, "Doc, I got a heart right here for my boy. I'm going to shoot myself, and you're going to take my heart and put it in my boy." And I won't tell you what happens. It's a pretty dramatic movie. Anyway, there's a happy ending. But watch John Q someday if you get some spare time. It's pretty good. All right, so guys, I have never asked questions about pectinate muscle here. You can see a little bit of extra detail. Basically, you need to know your chambers, you need to know your valves, you need to know your pipes, right? That's what you need to know. Chambers, valves, and pipes. And all these little extra details, like trabecular, carne, no, don't worry about that. It is good to know that this is the septum, interventricular septum. And there's a picture coming up that I'm going to show you why that's an important thing to look at. Okay, so this is a great picture, guys, of where the coronary circulation begins. Think about the blood pressure here. We've all heard that bypass procedure, like #1 killer in America, is either cancer or heart disease. Like they're almost tied. If you don't die of cancer, something happens to your blood vessels or heart. Well, why are coronary arteries talked about so much in the heart business? It's because the higher pressure blood vessels get plaquing quickest. So think about that. These two blood vessels are right off the aorta. If you go up the aortic arch, we're going to look at a picture later and talk about these here. And I don't want to mention these names yet, but this is going to the head. These blood vessels do go into the carotid arteries left and right, and the carotid arteries are often frequently clotted. They develop plaquing very quickly. So that is kind of why, these blood vessels are affected over our lives. When they do a triple bypass procedure, they basically add more pipes. They leave the ones that are there, typically, and they'll graft on more pipes, and they a lot of times use a vein in your leg called the greater saphenous vein. One of the procedures they do now that's the best, I've read about it, and we'll talk more about it later, but over here you've got a breast. On the left side, there's an artery to the breast tissue that's called the left mammary artery for mammary glands. And they have now come up with a procedure that they go find it and cut the artery at its point of insertion to the tissue, take it away from the breast tissue, and basically move it over to the heart. And because they only have to cut it one place, and it's an artery, it's real strong, it just goes directly there. That is the best way to do the bypasses now. And it's kind of weird. The reason why I'm describing this is because, like, you would think they're cutting an artery off of your breast. And what happens to your breast tissue, right? Well, usually it's okay from the collateral circulation. There are some times that it does become a problem, but it's just the best way to do it. Interesting stuff. So, coronary circulation. Here we have the venous return. I just left this in here to give you an idea. It has to go back. No special questions here. That's the back side of the heart, posterior. Here's a review from our muscle chapter. It's a nice picture, really. Guys, we're kind of moving, and I know you guys have your books. These are they go in pretty much order, don't they? Pretty good? Good. They go out of chapter 22, kind of in order. You know, just questions about heart tissue, cardiac muscles only in the heart, that's all. The aortic arch does not have cardiac muscle, even though it's right there next to it. It would have smooth muscle, but really, remember, the aortic arch is a lot of elastic, dense elastic connective tissue. But look at all the detail. You know, here's your T-tubules. We've seen those before. Intercalated discs. Remember that this heart tissue, cardiac tissue, has intercalated discs. It's always a question somewhere. Look at all the mitochondria. Muscle has a lot of them. Mitochondria. We get about 1 billion heartbeats in a lifetime, they say, which seems like a lot, doesn't it? Somebody checked me on that, and it turned out to be about 1 billion. If you do, 70 beats per minute for however many years, the heart kind of does a lot. Oh, I just left this in here because it's got a great view of the intercalated discs, right? Guys, on a test for the heart, test 3 organ systems, we don't review the muscle here. This was, more specific to the muscle chapter. Okay, so this is more pertinent to the new heart material we're looking at. The pacemaker. Guys, the pacemaker has a name, sinoatrial node. It really comes from the word sinus, and it's on the right atrium. And then we have another little place here that's closer towards the AV, right? So they basically call this area the atrioventricular node. Without getting too technical on this, let's just say that the pacemaker sets the rhythm, and that message has to go down to the whole heart, but we don't want the whole heart to contract as one unit. So we have a little bitty speed bump, I call this the speed bump, that slows down the signal. And that allows for the atria, both sides of the atria contract, and then 0.2 seconds later, that's what the books say, about 0.2 seconds later, that's more of a physiology number, but it's a delayed contraction of the ventricles. Now, where does the signal go through? It goes through the septum, right? There's this thing called the bundle of His, which really is just the nerves in this septum here. I usually put on a test what are the nerve fibers themselves. They're called Purkinje fibers. All of these nerves, and it's labeled it twice, right? There's Purkinje labeled here, and there is Purkinje labeled here. So all of these little bitty nerves are called Purkinje fibers. I usually ask that on a test for sure. Those conduct the signal. So the signal goes from the right side up by the right ventricle, or I'm sorry, right atrium, and you could say the SA node starts it off, goes down through a little bitty internodal pathway. Really, it's just nerves that go down, and then speed bump through the septum and around. So again, talking about damage to the heart. What if you had a problem where the heart attack affected the septum of the heart? Because those nerves feed off of that circulation in that region, you could have a major problem with the nerves. And that's where somebody might have a mild heart attack, survive, but they have to have a pacemaker to help with making the valves do what they got to do. There's something I always like to talk about AFib because it's so common. Guys, atrial fibrillation, honestly, I don't know. I don't want to spit out numbers, but it's like 10% of everybody. It's common. You know, and I might be off a little bit, but chances are 2 or 3 people in this room of 20 are going to have AFib at least some in their life. It might not become very bad, but it might affect you. My dad, when he was in his 50s, about 55 years old, he would wake up in the morning with a pulse of 130. This is from a resting, sleeping, metabolic state, right? And why is a pulse that fast when you're resting? Because the heart's not effectively pumping blood. It basically is a fluttering of the atria, and people have different severities of it. His was getting pretty bad, and the way I describe it, it's like a signature. You learn how to sign your name really good, and you often do that. But then if you start getting kind of sloppy and busy, your signature can start to evolve and become erratic. That's the same thing with this signal that our heart does. Our heart kind of forgets the good signal. So the procedure for correcting this actually works miracles, guys. They go up the inferior vena cava with a electrical burning device, and they go in here and they burn this internodal pathway. It's pretty crazy, right? They don't burn a lot, they burn some of it. And the reason why they do that is it's to slow down the signal. It actually works really good. Sometimes you have to have 2 surgeries because they don't want to burn too much at once, and it takes about 6 months for you to know how it worked out. But you know, this region here, if you have atrial fibrillation, you can live with it, but it can cause problems as you age. My dad's heart's perfectly fine now after the 2, they call it cardiac ablation procedures. They ablate. I had a friend die of ventricular fibrillation 2 years ago. He was 55. If your ventricles flutter, you are going to fall to the ground. It's not technically a heart attack because it's not a blockage of the coronary arteries. VFib is whenever you have a signal problem. That's the perfect thing to shock somebody for, right? You know, I told you I'd give you a bonus if I fall over and, you know, go get the defibrillator, right? There's one somewhere. We ought to find it. But you know, the defibrillators put people into normal sinus rhythm. So if you had a defibrillator when somebody went into VFib, if that's what you knew it was, and probably you don't know what it is, so you just shock them anyway, right? That's what you do. So anyway, so things that are kind of really interesting. AFib's common, VFib's very rare. All right, let's look at the next. Yeah, I kept this slide in there. They're just showing some detail, but Purkinje fibers, you can see where they go. I also left this slide in there. Guys, we've got a nervous system chapter. We ought to work on a little bit of that right now, not a lot, since it's in our textbook. We need to remember that the vagus nerve is the one that goes to so many organs. And this is the heart chapter, so they're showing the vagus nerve, number 10, going to the heart. The vagus nerve is parasympathetic. That means it relaxes the heart, it slows it down. The way that the nerves go to the heart for sympathetic, if you think about over here, it says sympathetic. This is going to be increasing the heart contraction, increasing the pace. Sympathetic innervation does not go through the vagus nerve. It basically goes through the spinal cord, and this is a kind of weird picture. It's kind of hard to follow. Basically, they're showing you the spinal cord down around T4, T1 to 5. You know, I am not going to ask you, this is a med school type question, guys. If you were in gross anatomy for med school, they'd say, which level does the sympathetic nervous system give rise to the innervation of the heart? And you would have to remember T1 to T5. So we don't need to be that detailed. It does kind of make sense because the heart's up there around that level, right? They pretty much kind of go where you'd think. And there is some research that says if people have back problems of that area, this nerve can be a little bit irritated and people might be more likely for heart disease. There's some weak, it's hard to do that kind of research, but it's out there. So, vagus nerve, parasympathetic, spinal cord, and when we look at the spinal cord later, we're going to see a chain on the side of it. So they call this a sympathetic chain of ganglion. So it's a chain, and this is bilateral. It doesn't show it in this picture, but it's bilateral coming off the nerve roots of the cord, and ultimately you get a nerve that goes to the heart in this situation. So don't get all worried about all this business. When you take physiology, they'll talk more about the medulla oblongata. You know, here we have a cardio-inhibitory center and a cardio-oscillatory center. If you were a neurosurgeon, you memorize all those places on all those things. We don't do that, okay? So it's just kind of interesting to look at it, but we don't need to memorize exactly where all that is. Wow, that's the end of that. So we've got a few minutes. Let me show you what we're going to look at in chapter 23 before we pack up. Chapter 23 is the blood vessels. And, okay, let's see. Guys, this is probably more new for most of us because, you know, Biology 115, I can think off my hand the list that they give you: carotid artery, renal artery, iliac artery, subclavian artery probably, you know, jugular vein, renal vein. That's basically what you saw in the pig, right? So, from current slide. Chapter 23, we're going to see, oh, I changed this, but it didn't save it. Anyway, let's look at just some basic things about this chapter. There's a nice picture that kind of is similar to what we saw with the heart earlier. And let's talk about the big differences between an artery here on this side and a vein. Definitely arteries are thicker. It makes sense. The general structure is the same as far as the layers. You know, every one of these has, and the word tunic comes from the word tent. So it doesn't really look like a tent, but basically in anatomy, a structure that is flat and can be wrapped around something, which that's the way they got the idea of a tent there. The tunica intima is the inner epithelium, very thin. We don't need to get into the details of, internal elastic lamina. I just wanted to show you because it's important to think you can have delaminization of these vessels. It's very common to have a situation where a clot will grow or something will happen in between. Delaminization would be separation of the layers, and you could get calcium growths, you can get all sorts of stuff. A test question that is I like this one a lot. Vasa vasorum. True story, guys. I got to tell you about this. This is the blood vessels to the blood vessels. That's what that is. Vasa vasorum. So it's pointing to the little blood vessels in the blood vessels. So yes, the smooth muscle layer of this thick artery needs some blood vessels to it itself, right? That's what the vasa vasorum is. I don't know if you guys have ever heard of syphilis. Syphilis is a bacterial infection that if you don't treat it, you end up getting the vasa vasorum affected. And I'll never forget, guys, and it's a perfect day for this because my voice is very rough. My neuroanatomy teacher long ago, he said, don't ever go out with a prostitute with a deep voice. Okay? And back in the old days, this is a true story, tertiary syphilis, one of the last things you start getting is a deep voice because the vasa vasorum of the vocal cords has basically started to fall apart. So people get deep voices. Tertiary syphilis, the worst case, you'll have an aneurysm. And you will have a popped blood vessel from that disease, which it's amazing because it's bacterial. All you got to do is take an antibiotic when you get it. But people back then didn't know. You know, honestly, out of any of the diseases, STDs, you don't want any of them, but syphilis, it's bacterial. Just take some antibiotics early and you're going to be okay. But if you don't treat it, you end up having aneurysms and you can die from it. And a deep voice. Look at the capillary bed down here. Look at the little basement membrane. This is a one layer thick kind of deal here, right? Very thin epithelial tissue. So also look at the valve. Guys, for sure, there are no valves in any artery ever, okay? But there are some valves in the leg veins. And it talks about it later on in this chapter. So leg veins have valves. You should never massage your legs towards your feet. You should never push on your legs towards your feet because it's basically taking the blood flow and pushing it backwards. And you can break these valves. People have venous distension later on in life. Some people have bad veins anyway. I can tell you a story about veins next time we're here. It's quite amazing. I've seen my dad again had a vein problem and he had a treatment and it fixed it. It's absolutely amazing. But these veins in the leg have valves and they can break. Here's a great slide of a transverse section through probably a leg. Slice. And it just shows all the adipose that kind of goes around and protects. Look how thick that artery wall is. You can automatically tell that's an artery. Vein. Arteries are always deeper, so the bone would be somewhere over here towards the bottom. Anyway, that's just a nice little picture. Typically, the veins are much bigger in circumference than, if you think about the internal lumen diameter, look at the size of that compared to that. Blood flow would be the same volume at those locations, pretty close to the same volume, but blood velocity would be different, for sure. And blood pressure would definitely be different, right? We're going to finish up on this slide, and then we're going to call it a day after this. I included this slide in this because basically they're showing us how if you were up closer to the heart, you're going to have thicker layers in general everywhere. And then down at the capillary bed, you only have one layer thick. There's actually a better picture I wanted to show you. Let me jump ahead. Right here. Guys, I'm not going to ask you any specific test questions, but take a look how small the capillary bed gets. One red blood cell can go through at a time. And there are technically 3 types of these capillaries. I'm not going to ask you which one's which, but basically it kind of makes sense. This one's continuous. We have simple squamous epithelium here. That is a question I might ask. I probably did it on the tissue chapter, right? Actually, probably didn't. But capillary beds are simple squamous if they're one layer thick. And the basement membrane here is the clue. All epithelial tissue has a basement membrane, one layer thick. That was basically why the lungs, the example in our tissue chapter for lungs was simple squamous epithelium. But you could also use that example for any capillary bed anywhere, right? And look at this one over here. You can imagine this one would be even more loosely packed. Things could cross easier because the ultimate goal of these things here are for exchange of nutrients in the body. So let's call it a day. I'm gonna